Okay, so thank you everyone. Today we have Dr. David Fuks from Paris, who will be talking about errors in surgery. Thank you, Dr. David, for joining us, and the floor is yours.
Thank you, Dr. Hisham. So this is a very special topic today. This is a very special topic. It's a French presentation, but there is not so many texts, so it won't be so difficult to understand. This is a very atypical topic. So what does it mean, error in surgery? When you check on Google, you find this. So error and complication about aesthetic surgery. But what does an error mean? So this is a failure to accomplish an expected action or schedule a planification just to obtain an aim. But what does surgery mean? This is a medical discipline specialized in the treatment of disease and trauma, consisting to do with your hands, with the help of instruments, some surgical procedure on a living body. Okay, so what does a medical error, what does a surgical error? Actually, this is very interesting because in 2000, US people checked what a medical error has as a consequence. And in a population of 45,000 patients, it represents 10% of all deaths. And in 50% of all medical errors were evitable. So it could be treated and avoided. In US, this is the 8th cause of death before car injury, before breast cancer, and before AIDS. So this is a very, very, very frequent cause of death. And when you focus on publication about security of patient, you can see that before 2000, nothing was done. And after 2000, this is a beginning of many letters on review on guidelines about medical error. So what error in surgery means? So first of all, this is a specialty, a medical specialty with high risk. So just to take an example, we can focus on the gallbladder. Gallbladder is in France, it's very, very frequent procedure. It's the same in Egypt. So it means that in France, every year, 135,000 cholecystectomy are done annually. So this is very, 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 very frequent. This is a very simple procedure. This is just need to remove the peritoneum around the gallbladder, to identify the cystic duct, to cut the cystic duct, and to remove it. The problem is, for very simple surgery, the rate of bile duct injury is not so rare. It's frequent. So it means that a leak from the cystic duct, or clip applied on a common bile duct, or cautery, or injury, or complete section of the on the CBD, this is frequent. And it used to be very, very rare when you focus on open approach. But with laparoscopic approach, the rate is more than 1%, 1.5%. So it means that in France there is a trouble with the flight every day. So this is a Boeing 747 which crash every day. So it's very frequent. It means that this is 200 patients a year in France, and sometimes could be a disaster. So it means that you can observe a section of the right branch of the portal vein and right branch of the hepatic artery on the right part of the bile ducts, and it decreased the long-term survival. It decreased the quality of life. Here, this is all the symptoms described in patients with bile duct injury, and even more than 15 years post-operative. It means that you jeopardize the life of this patient with bile duct injury. So even after reparation, so after a surgical repair, the quality of life is not so good at all. So there is different mechanism. So different mechanism. This is a different variable factors. So patient factor, technology, surgeon, and organization and management context. So it means that most of the time this is not only one factor, but there is multiple factors. And sometimes the patient does not have a simple anatomy. So anatomy could be different, could be very surprising. It could be dangerous sometimes. And sometimes with inflammation, you can believe that the cystic duct is in the middle, just here, and you cut the CBD, because there is a difference between appearance and reality. So it means that you see on the schema on the left side, and actually on the right side, this is a common hepatic duct. So it means that you make a mistake, you make an error, and there is some dramatic consequence. In France, when you focus on complaint of patient, this is a second cause of complaint, and it represents 50% of all complaints. So this is a real problem. And most of the time, the complaint is about communication between the surgeon and the patient. When the surgeon explains to the patient preoperatively that this is a very easy procedure, this is a 20 minutes, 40 minutes, and everything will be done, and no consequences. And this is a problem. This is a problem between the nightmare on the reality and what do the patient expected. So the problem is communication between the surgeon and patient. About technology, this is very interesting, because if you focus on technology, you can observe that in minimal invasive approach, you don't see the reality. You see the image of reality with a 2D visualization. So this is a very nice view, but sometimes there is some smoke, sometimes there is some blood, sometimes the camera is dirty, and unfortunately, laparoscopic approach can increase some perception error. So it means that here, for example, here you see a right triangle. Okay, but the right triangle does not exist. It's just in your head, because there is no right triangle. This is only your mind which builds this right triangle. And exactly the same with a single port, with a flexible port and flexible instrument. So actually, this is a huge trap, and we should be cautious, because sometimes you don't see the reality. So this is very interesting. This is a Zollner optic illusion. So it means that when you see the line, you observe that they are not parallel, but actually they are parallel. But in your mind, you feel like if the line were not parallel. And with the technology, with the laparoscopic tool, you track very fast. You can injure, you can cut the wrong duct, and so on. And sometimes here, this is a forest of clips. So 6 or 7 clips in the same duct. Of course, this is not a cystic duct. So it means that the laparoscopic approach can increase the difficulty to decrease the understanding of the anatomy. The third point is the surgeon. Being a surgeon between the myth and the reality. So this is very interesting, because as I told you, cholecystectomy is a very frequent disease, is a very frequent procedure. And this is very interesting. But when today, as an expert surgeon, you go to the OR and you know that you need to do a cholecystectomy, you are okay, because you know the procedure, you know very well the procedure. You did hundreds and hundreds and thousands and thousands. So it means that you feel at ease. It's an easy procedure. So it means that this is a repeated experience. This is a clear display. You're in a good mood, and everything feels familiar. It feels true. It feels good. And the prime is, even if you have an experience, you can make mistakes. So this is a Daniel Kahneman books. It's a very interesting book, and he explains that he has a Nobel Prize in economy. And Daniel Kahneman explains that there is two systems of thinking. This is a slow one and a fast one. S1 means the fast one. This is this one. And the fast one, this is a intuition. This is effortlessness. So it's based on experience. So you know everything. When you go home after your busy day, you move back home and you know how to reach your house. It's not necessary to check if you need to turn on the left, on the name of the street. You don't know, because this is S1. S1 is a very effortless thinking. It's very fast. You don't think, oh, where? And on the right side, this is a S2. S2 means it needs some concentration. It uses some energy. So you stop. For example, you close your house door every time with 2 turns. And after a busy day, you go back home and the door is unlocked. So your mind stops. You understand? Your mind stops. Say, oh, is someone getting my house? And this is S2. And a good surgeon needs to switch from S1 to S2 intraoperatively. It means that everything is okay, but if you stay in S1, it means that you're dangerous, because even if there is a modification of anatomy, you won't take into account. And the problem is, if you are only on S2, you won't do something, because, oh, it could be the CBD, oh, it could be the CBD, oh, or maybe there is, and you cannot go and do the cholecystectomy. So a good surgeon and a good person needs to use is S1, it's S2. So it's very interesting, very interesting. So this is only a thinking fast and slow from Daniel Kahneman. But the indication for the surgery could depend of many non-clinical variables. So it means that if the surgeon is tired, the previous bad experience, if your last Whipple, the patient blood loss was 2 liters, you can be sure that the next one won't be so easy. So it's not the same problem. If the patient is a best friend of your colleague, this is not the same pressure on your shoulder. If you don't have any access to the operative theater, there is some pressure, and everything can influence the quality of the surgery. And you should not forget that 1/3 of surgeons, not only in France but in the world, is in burnout. So it means that there is a risk between burnout and medical error. So you need to be very cautious about this. And we work with a team, with a scrubbing nurse, anesthesiologist, anesthetist, and so on. So this is a difficulty, and this is a environment. So sometimes the pressure of the hospital can increase the difficulty. And this is a very interesting point. When you are a team in an OR, when there is no work at all, the team is not so good. And if you increase the number of cases a day, for example, the quality of the team will increase. But if there is too many patients, too many procedures, and if you don't have a scrubbing nurse, the problem is you will find an accident. You will have some difficulty to do and to achieve the surgical program. And this is the reason why it's not a good idea to do a laparoscopic cholecystectomy for acute cholecystitis in the night shift, because it's not the better environment to treat this complication of this accident. So we know today that there is different mechanism of error from organization, for supervision, about dangerous situation, and with many things. So we need to be cautious. So maybe we need to change. We need to change the concept. So it means that we used to be a performance surgeon. This is very important, to be performance. So the performance is just to be able to do something special in a special situation. So it's good. The prime is very difficult to draw any conclusion, because you say, yes, I did a Whipple like that, but the patient was thin, the patient has an ampuloma, and this is not a large tumor, this is not a fat patient, and we need to be competent. So competence is different. It's to be able to do many things in many situations, and it need to be very strict about the training. And the good thing is about the experience feedback is much better. So you need to train a team. So yes, this one is not so good. Okay, and how can we change this concept? First of all, we need to listen to the specialists. So it means that Daniel Kahneman explains that we are prone to overestimate how much we understand about the world and to underestimate the role of chance in events. So it means that sometimes it works, but sometimes it doesn't work. And you just need to keep in mind that this is a complex system. It includes many things. So it's not so easy to deal and to be a secure. So here, this is very interesting. This is very interesting. This is a scale of security. So it means that this is an unsafe system and this is an ultra-safe system. Here, on the ultra-safe, this is a nuclear industry or railway or civil aviation. On the opposite here, this is a guy who worked to hike the Himalaya. This is not the same system. So it means that this is like finance, like a war in Ukraine, for example. This is a unsafe situation. Unsafe situation, it's you cannot control the different elements. On the right side, you control everything. You try to control everything. For example, in medicine, it means that blood transfusion is very, very safe. So 2 days, there is no accident of blood transfusion. About radiation therapy, it's the same. Radiation therapy is quite very, very safe, not 100%, but very safe. And the problem is surgery. Surgery, we are here. So we are in the middle, not so safe, but we are safe. And interestingly, the different systems, so ultra safe, very unsafe, safe, and ultra safe, the concept is totally different. So taking risk here is the essence of the profession. So the power is to experts. If you want to hike and go to the top of the Himalaya, you just need to talk with an expert, the guy who succeeded 2 weeks ago, and the power is to experts. In a safe system, the power is to the group. So the risk is not thought, but it's inherent to the profession. This is surgery today. And on the right side, we need to maybe to switch and to move from a safe to ultra safe. So the risk is excluded. And the power is not to the surgeon, the power is to regulation, to supervision. And sometimes it's not very well tolerated by surgeons because say, I'm the boss. Yes, but when you are the boss, maybe the risk is not so well controlled. So if you look at the anesthesiology, it's very interesting because the direct rate of mortality decreased by 10 in 20 years. And how did they do? They follow the rules. Of course, this is not the same. This is not the same job, of course. But we need to keep in mind that there is many complications inherent to different mechanisms as described before. So following the rules is very important. Just not to make a groin hernia in the left side if the patient suffer on the right side. Follow the rules. It's just need to follow the 39 different steps in a cholecystectomy. In France, Nobody follows these rules. But I'm very, very confused because this is a very important. The critical view of safety is mandatory. And in France, the surgeons are quite proud of themselves and the things that they're able to do. But the problem is you need to be safe and you need to follow the rules. Maybe the simulation can increase the quality of procedure, like in a cockpit, like for pilots. And simulation in surgery is very, very difficult and very different compared to aviation. So it means that this is not the same. This is a computer hidden in a plastic body, and it's not real. This is not the reality. They are very far from reality. So of course there is a new system. For example, SimLife system. I'm sure that you don't know. This is a French system developed in a very small university in France. But this is cadaver with intubation. There is ventilated, and there is some not blood, but this is a fluid injection with beating injection. So it looks like a real patient. So it's very interesting to train with this kind of model. And of course, the robotic approach and the different progress will increase the safety, like a GPS, like something which helps you to do a safe things. Like a pilot, like this is like a cockpit. This is two surgeons, and there is to check and say, okay, this is the right branch of the portal vein. We need to cut it, and so on. And maybe tomorrow, the new simulation, you can be trained at home to prepare the surgery of tomorrow at home with a virtual reality. So, as a conclusion, error or mistake is not a fault. To do an error is normal in surgery. This is a process of teaching, of not a teaching, of learning, just to be trained. And simulation can increase our skill. And when the error is understood, it's done only once. And we need to share just to avoid repetition of this different error. And the fault is only to hide the error. Thank you very much.
Thank you, Dr. Fuks, for this interesting presentation.
Different, no?
Yes. Let's see if we have any questions from the audience. Please, if you have any questions, raise your hand. I don't expect many questions because the topic was straightforward.
Yes, but are you happy, Isham, that I did this or not?
We have a question from Dr. Mustafa El Shazli.
Do you hear me?
Yes. Yes, we can hear you. Okay, now we can't hear you. Dr. Mustafa, please type your question. Type your question in the chat. No, we can't hear you. Dr. Mustafa, please write your question in the chat. Hello? Do we have any other questions? The question is, CBD injury, is it considered fault or crime in your country? Yeah.
No, it's not a crime. This is an error. No, this is not a crime, not at all.
Okay.
In Egypt, this is a crime. No, this is not a crime. This is a mistake. This is so we need to pay. The surgeon don't need to pay. There is insurance, of course, but no, this is not a crime. Absolutely not.
Okay. Do we have any other questions from the audience? Please, if you have a question, raise your hand.
I hope you enjoy. That's all. So it's not a promise. You don't have any question, but just this is a different way.
Yes,
to think.
it was a different topic. Yes.
Yes,
Dr. Munir, you have a question? Well, wait.
No?
Hello?
Hello?
Yes, Dr. Munir, we can hear you.
You hear me?
Yes.
Yes. Can you give us an example of difference between an mistake or error and negligence?
For example, to cut the CBD. Cut the CBD. This is an error. This is not a negligence. This is a bad interpretation of the anatomy. Actually, this is an error. You thought it was a cystic duct, but it was CBD, and this is an error. You did not understand the reality.
And negligence?
Negligence. You want to discuss between the difference between an error and a negligence. Yes. Yes, it's good. Very interesting. Very interesting. The negligence is not to do the best to find a solution. So it means that if you have some bile in the surgical field after the cholecystectomy and you did not put a drain, you did not try to do a cholangiography, and you did not make a conversion, this is a negligence. So this is different. So you did not take into account what you have just in front of your eyes. This is different. To cut the CBD is maybe sometimes it can be explained by the huge inflammation. It was very late in the evening. The patient was very fat, and the anatomy is not clear.
Okay, thank you.
Okay, do you have any other questions? Okay, thank you, Dr. Fuks. That was definitely an interesting topic.
See you soon.
Yes, I think we will meet again in 3 weeks or 4 weeks.
No problem. It's a pleasure for me. Okay.
Okay, thank you, Dr. David,
Thank you.
and everyone have a good night. Thank you all.